thank you for tuning into the show. In this episode, I interview Professor Stephen Lawrie about anxiety and depression. If you enjoy these podcasts, please hit the like and subscribe buttons or visit iforgottooaskthedoctor.com. I'm Dr. Gail Busby, and this is I Forgot to Ask the Doctor. Hi everyone, thank you for tuning into the show. In this episode, I'm going to interview Professor Stephen Lawrie about anxiety and depression. Stephen is a consultant psychiatrist and professor of psychiatry and neuroimaging. He is extensively published in the medical literature and has authored several books about mental health. He is committed to reducing the stigma around mental illness and has had many leadership roles. He is also extremely active in training. I am truly honoured to have him on the show today. Stephen, welcome. Thank you so much for joining me today.
Thank you, Gail. It's a pleasure.
So, Stephen, I'm always fascinated to learn why distinguished colleagues like yourself chose their particular area of medicine in which to practice. So can you share with us why you chose to work in the field of anxiety and depression?
Yeah, well, I'm a psychiatrist, and as I was training in medicine, I have to say I wasn't particularly enjoying the rest of medicine, but I found psychiatry in fourth year as an undergraduate and never really looked back and knew that's what I wanted to do, and I've never regretted it. And I, like all psychiatrists, like many doctors actually, I see a lot of people with anxiety and depression, although my main clinical and research interest is in psychosis, especially schizophrenia. But those people too also get anxiety and depression. So it's very common. And I am interested in it because of that, really.
Okay, thank you. So, Stephen, as you know, this podcast is aimed at educating patients. And as a result, we try to avoid medical terminology as much as possible in order that it remains as accessible as possible to everyone. So let's start with the basics. What exactly are anxiety and depression? Are they two separate entities, or are they illnesses along a spectrum of mental health issues?
So anxiety and depression in the kind of everyday use of those words are obviously things like fear and concern on the one hand and sadness and unhappiness on the other hand. When they become medical or psychiatric illnesses, they are severe, last for a long time, have a whole bunch of associated symptoms, and they are commonly associated. But, just like the feelings of fear and sadness are not the same, the illnesses that are anxiety or depression are not the same. So a lot of the symptoms overlap, some of the treatments overlap, but mainly not. And they are commonly associated. So about 50% of people who are anxious will be depressed, and 50% of depressed people will be anxious. But they're not one and the same thing. They're best thought of separately, I think.
Okay. And can you just clarify for us exactly what the symptoms of the two of each would possibly be? Anxiety on the one hand and depression on the other.
Yeah, so anxiety is primarily a fear or concern about a particular situation, or occasionally all situations. And the classic examples are things like phobias, where people are afraid of particular objects or things, like children are afraid of thunderstorms or cats or dogs sometimes. And then in adolescence, you get a condition called social anxiety, which is primarily a concern about how one is seen in public and public performance and that kind of stuff. And then you get panic attacks and generalized anxiety, which tend to present in adults. And panic attacks are panicky feelings where people think they might be about to collapse or have a heart attack or even die. And sometimes that's associated with agoraphobia, fear of going out. Depression, on the other hand, is primarily a feeling of sadness. And when it becomes an illness, it's feeling sad or depressed most of the time for at least 2 weeks. And there's a whole range of associated symptoms, particularly tiredness, a lack of enjoyment in previous things that people would have liked doing, sleep disturbance, appetite disturbance, poor memory and concentration, and classically negative thoughts. self-critical thoughts, negative thoughts about the outside world, and hopelessness about the future. And sometimes when people become hopeless, they also start to think about they wish they were dead, or they start to think about how they might actually harm themselves. So those kind of suicidal ideas are a classic symptom of depression. So those are the kind of main differences, I would say.
Okay, thank you. Thanks for clarifying. That's really, really clear. So whenever, in all my interviews, I always ask about risk factors for certain conditions, because there are certain predisposing factors to conditions that one may alter, perhaps with lifestyle modification. But there are other factors, so for example, genetic factors that you really can't change. So are there any recognized risk factors for anxiety and or depression? And is there, in turn, anything that people perhaps can do to minimize the risk of ending up with these disorders?
Yes, I mean, there certainly are very well recognized risk factors for both conditions. Some of them are you can't do anything about, like genetics and family history, for example. And some of them you can do things about. So obviously the anxiety and depression run in families, just like lots of traits, and there's not much one can do about that. The other kind of risk factor for anxiety and depression at a young age are childhood adversities of one sort or another, abuse, neglect. And there's not a lot you can do about that after the event, although sometimes psychotherapy or other talking treatments can help adjust to those things or acclimatize to them. But there are then kind of risk factors that people can do things about. So alcohol and drugs are very common causes of anxiety and depression. And sometimes people drink or take drugs to try and deal with anxiety or depression. That's not usually a good idea. Usually it makes things worse. And so if one is feeling anxious and depressed, particularly if using too much alcohol or taking illegal drugs, one of the things you can do is try and cut those things out or reduce them to more healthy levels. And in general, the other things that people can do are exercise and healthy living in a general sense, getting out and about, exercising oneself mentally as well as physically. So those are things that people can do. And I tell all my patients with anxiety or depression, or indeed most other illnesses, that the things they can do to help themselves are, eat and live as healthily as possible.
Yeah, it's amazing. That's really a recurrent theme in all my podcasts.
Sure.
Just general good health, diet, exercise, really, really important.
It is.
And coming on to that, are there any, so some of the symptoms for anxiety, I suppose, would be feeling stressed, maybe palpitations, etc. Are there any medical illnesses that may mimic the symptoms of anxiety and or depression? So I'm thinking off the top of my head, things like thyroid disease. So excessive thyroid hormone, hyperthyroidism can cause palpitations and your heart racing and sweating, and that I can see might mimic anxiety. Are there any others that people should be mindful of?
Well, yeah, those conditions that are, as you mentioned, that are looked after by endocrinologists, people who specialize in diseases of the glands that produce hormones in our body. Those are the very same conditions that can cause anxiety and depression, or at least manifest anxiety and depression. And so, as you say, an underactive thyroid, hypothyroidism, commonly causes depression, and sometimes can be the cause in people who are depressed. So it's always worth looking for that. And similarly, hyperthyroidism and overactive thyroid can be associated or cause anxiety. And you can get similar conditions of the adrenal gland sitting at the top of your kidneys, Addison's disease or Cushing's disease, which are associated with anxiety and depression. So it's not common to find those because our health system still works reasonably well, and those kind of conditions are still usually picked up by GPs or other doctors. But occasionally, you do come across people who've an undiagnosed endocrine or some other condition that might cause anxiety and depression. I mean, the other general class of illnesses that's worth thinking about are various chronic infectious illnesses. We all know that when we get a bug or the flu, we feel worse. And if you've got anxiety and depression, makes them a lot worse as well.
Yeah.
And so there are chronic infectious illnesses like brucellosis, Lyme disease, tuberculosis, that can be causes, particularly of depression. And it's often worth making sure that that is not the case in a particular person, particularly if they've got chronic depression, which has not responded to the kind of standard treatments. You need to start thinking about other potential causes.
Right. Very interesting. So I guess the take-home message is, if you have these symptoms, go along to your GP, who will take a full history, examine you as required, and do any investigations to rule out that there may be a physical or medical cause before taking other steps. And what do you think are the symptoms particularly that should prompt people to say, okay, I'm experiencing this, I really need to seek some help, I really need to seek some medical attention or some support? How would you advise those people?
So in a general sense, beyond any medical concern, you mean? So if you've just got anxiety or depression, I shouldn't say just, but if you've got anxiety and depression which don't have an identifiable medical cause, it's still worth going to see your GP. They are still the point of initial contact for most people with anxiety or depression. There's a range of other support agencies, and we can maybe come back to that later. But there's no one symptom, I would say, that says, oh, you must go and see a doctor about this. Okay. Except possibly if you are feeling suicidal. So obviously, if you are depressed and suicidal, or even severely anxious and suicidal because it's all getting a bit much, you don't see any light at the end of the tunnel, it's always worth going to see your GP, who will refer you on to mental health services, psychologists and psychiatrists, if they think things are urgent, and they often are in that kind of situation. But other than suicidal ideas, and particularly plans, I wouldn't say there's any single symptom. The thing that I would say, and I use in my clinical practice all the time, is just how distressed and disabled people are by anxiety or depression. So if you've got relatively mild or even moderate levels of anxiety and depression, you can very often struggle on, and things will get better with time or with treatment. Sometimes even work can be a kind of helpful distraction if you enjoy your job, or at least half enjoy it. And things like relationships and doing things with friends as well. But if you are no longer, inclined to do any of those things, you're extremely distressed, you can't work, you can't relate to others because you're too anxious or too depressed, that is also, I would say, a reason to go along and try and sooner rather than later, and try and get some help.
Okay. And sometimes we encourage people to seek support or seek help. And part of, I think, educating patients is to let them know what to expect when they do go along for help. Yeah. So can you just enlighten us as to how these conditions are diagnosed, and what would a patient who has these symptoms expect when they go along to their GP? Because sometimes that can be a barrier to accessing help in healthcare, that you're not sure, what you're going to be faced with.
Absolutely. And I think people also still feel that although the stigmatization of these conditions is less than it used to be, I think people still feel a bit reluctant to admit that they've got anxiety or depression. Yes. Maybe even to their closest friends and family. They might be a bit afraid about how any GP might react if they say, oh, I've got anxiety or depression, or I think I might do. But I would say from the off that, anxiety and depression are very common. They affect probably 5% of the population each at any point in time. And probably about a third to a half of all the patients that a GP sees have got some level of anxiety and depression. So they are very, very able and skilled and experienced in diagnosing and treating these conditions as part of their basic training. It's a large part of their day-to-day job. And they are, I think the vast majority of them are quite understanding and supportive, and not stigmatizing of these conditions. So I would encourage people to go and not let fear of stigma or whatever it might be put you off. When you do go, it is standard practice in most GP practices across the UK, at least, and many other countries around the world, to get people to fill in standardized rating scales or screening scales for depression, particularly. There's something called the PHQ-9, the Patient Health Questionnaire 9 item, which has 9 questions about depression and the sorts of symptoms I've already talked about.
Right.
And so if the GP thinks that you may be depressed, they will ask you to fill that in. And that's a fairly reliable indication, if you score highly on that questionnaire, that you are depressed to the point where you might benefit from treatment. Obviously, the GP will ask you questions about that or anxiety. There are rating scales for anxiety, but it's a little bit more complex. And then if you do, in discussion or on the rating scale or both, come across as needing treatment, then the GP is in a position to, prescribe antidepressants or refer you for counselling or psychotherapy of some sort, or if that doesn't work, refer you to a psychiatrist. So I would encourage people to go and see their GP sooner rather than later if they are concerned they're anxious or depressed.
Okay. And so you've touched on it a little bit about treatment options. So, say I went along to my GP and I discussed my concerns. I did the questionnaire, and the diagnosis of one or other is made. What treatment options are likely to be discussed with me? And so, can you go through what options are available and what determines kind of which option is likely to be used as first line? What determines that?
Yeah. So there's quite a wide range of treatments, and that is one of the reasons that most people with anxiety or depression will respond to treatment, because if they don't get better with one, they'll get better with another. But usually they do quite well even with the first treatment. I mean, broadly, you can think of it as talking treatments or psychotherapy on the one hand, and pills, especially antidepressants, on the other hand. Antidepressants are actually, some of them particularly, are also very good treatments for anxiety. So obviously it's easier and quicker for a GP to prescribe you an antidepressant, and you can get it more or less immediately, and within a week or two you'll probably be feeling better. But some people don't like to take pills and prefer to be referred for counselling or kind of more structured psychotherapy like cognitive behavioral therapy, CBT, from a psychologist. Those are, generally speaking, those approaches are more or less as effective as antidepressants in most cases. So again, most people will get better. The problem obviously is that it can be some time before your referral gets through the system to be seen, and certainly weeks, sometimes months, I'm afraid to say. So that is a problem for some people. If you're really quite unwell, distressed, disabled, especially if you're suicidal, you need something done sooner rather than later. And so the first port of call is very often antidepressants. There's also a very limited capacity for psychological therapies in the NHS, although through the IAPT programme in England and Wales, increasing access to psychological therapies, IAPT, that has undoubtedly increased access to psychological therapies, but it still doesn't meet all the demand. But those are the sorts of things that you could get to start with, at least.
Okay, thank you. And what determines whether someone is referred to a psychiatrist, so someone like yourself, versus a psychologist, or put on antidepressants? Is it failure of first-line therapy? Is it how severe the condition is from the outset? What might determine the kind of referral pathway?
Yeah, I mean, I should have said already in response to that question, but it's kind of relevant here, the previous question, but it's kind of relevant here as well. Patient preference, what people want in terms of drugs or talking treatment is obviously a key consideration, and some people want drugs and some people want talking treatments. If someone doesn't respond to a talking treatment, then the obvious thing to do is to try an antidepressant. If someone doesn't respond to an antidepressant, then that is the typical time that a GP will refer someone to a psychiatrist. Sometimes some GPs will try 1 or 2 or even 3 different antidepressants, or increasing the dose of the first one. But that's the kind of probably the most common referral of any patient to any psychiatrist is depression, which has not responded to the first line treatment, and anxiety similarly. So the GP is also in a position to refer to psychological services if someone hasn't responded to the first line antidepressant treatment, for example, or relatively simple counselling in whatever agencies people may have used. One can refer to clinical psychologists who are trained and skilled in cognitive behavioral therapy, CBT, which does also seem to work a bit better than some of the other psychotherapies. So those are the kinds of things that would be the first things to do if someone hasn't responded to first line treatment.
Okay. And can you just describe a little bit about what's involved with CBT?
So yeah, CBT was devised actually by a psychiatrist called Aaron Beck, who very carefully developed the psychotherapy based on observations of people with depression. So as I said right at the beginning, people with depression characteristically have negative thoughts about their self and the outside world and the future, both for them and the world. And so CBT is really designed to attack, if you like, those negative thoughts. It's a kind of here and now, common sense like psychotherapy where people are actually asked to, well, what's the evidence you've got that you're such a bad person, or the world is in such a bad place, or that the future is so hopeless? And they are encouraged to kind of challenge those views. What's the evidence you've got for and against your own worthlessness or negativity? And through that and a range of other exercises to think more positively, to be more realistic, to be active, to engage with people in the outside world, it's a well-proven psychotherapy, particularly for depression, and there are variants of it for anxiety as well.
Okay, thanks. That's really clear. And are there any risks associated with the different treatments? There might be, I guess, risks associated with the pharmacological, the antidepressants, or even, I don't know, whether the CBT or talking therapy has any risks involved?
Well, yeah, I mean, I think any potent treatment of whatever sort is likely to have adverse effects or side effects. It's kind of, if a treatment doesn't have any side effects, one has to question whether it's got any beneficial effects as well. But
True.
So yes, those are kind of most well described and recognized with antidepressants. So yes, antidepressants have a range of side effects. Some of them are actually quite helpful. Some of them are actually, positively unpleasant. So a lot of the antidepressants, particularly the older ones, are quite sedating. But if you're not sleeping as a result of anxiety or depression, that you can take them at night and they can actually help you sleep. And that's actually one of the ways that they can help very quickly. If you're not sleeping, an antidepressant will very often help you sleep better and feel generally a bit calmer during the day. But they can also cause, the older ones tend to cause dry mouth and constipation, sometimes a bit of difficulty passing water or focusing your eyes. People tend to get used to those things quite quickly, in my experience, and particularly if they're warned about them and they expect them, they're not such a big, shock, horror, surprise. There's no really long-term adverse effects of taking antidepressants, as far as we know. The big issue at the moment is whether or not they cause some kind of dependency. They're not addictive in the same sense that alcohol or illegal drugs are, but when people stop them suddenly, they can get what I think is best described as a kind of withdrawal reaction. And so, once you're better or you're changing between antidepressants, you should do so carefully and cautiously. You should, roughly speaking, half the dose every month or so, and be particularly careful as you get down to very low doses about how you slowly phase it out. And above all, don't suddenly stop these drugs. It's not entirely clear how common, cessation or withdrawal reactions are, but I've seen some people who've had very nasty ones. Some people report them, but in the majority, I think the majority of people can take antidepressants without having those kind of problems. And then on the other hand, if you're talking about psychotherapies, there's a kind of tendency, I think, for people to think that psychotherapies, getting to the core of the problem, rooting it out, and kind of dealing with it forever. Regretfully, that is not usually the case. Psychotherapy undoubtedly helps, just like antidepressants help. But, to continue with the example of childhood abuse, for example, psychotherapy is not going to change the fact that that occurred. It's not going to change the fact that, you've had to deal with that up until now throughout your life. It's probably going to help you deal with how you reacted to it, how you feel about it now and going forward. And so it's not, both are more or less equally effective, and both have adverse effects. The problem with psychotherapy, and this has particularly been recognized for a long time by the psychoanalysts, is that it can have adverse effects. There are some people who have had difficult experiences in childhood, and the more abusive your childhood has been, the less likely it is, to be frank, that psychotherapy is going to help. And there are some people whose relationships with their primary carers, usually the mum, sometimes the dad or others, there's sometimes that has been so difficult or so traumatic that it's best not to dig around in there, and best to sometimes just leave alone, or at the very least to have a kind of latter day commonsensical CBT like approach. But even then, that's the CBT is largely what the IACT people are providing, and it's still around about 10-12% of people report long-term adverse effects of psychotherapy in that context even.
Okay, so that's really interesting. And tell me, what would the kind of, I know it's variable, highly variable, but generally speaking, would the goal be to be on antidepressants, for example, for a predetermined length of time? Or is it more likely that kind of once you're on them, you just carry on indefinitely? And so too for counseling, is the goal to have a course, if you like, or is it, and I understand it will vary from person to person, but just generally speaking, can you just enlighten us about that? Because some people think that, I have patients who obviously, have anxiety and depression as well as their gynecological issues. And they could be quite reluctant to start on antidepressants. It's been discussing, but I want to start because I feel like that's it then. I'll never come off them. So can you just enlighten us about that?
Yeah, hopefully. There is good evidence from clinical trials that if you respond to an antidepressant, you should continue to take it for about a year, and perhaps longer, perhaps as long as 2 years once you've responded. And the reason for that is that it keeps you well. So the biggest risk for a relapse in depression is immediately after your last episode. And if you if you stop a treatment as soon as you've got better, you've got, roughly speaking, a 50-50 chance of becoming depressed again. If you stay on them for a year or more, you reduce that chance of becoming depressed again to roughly 10% or so. So that's quite a big difference, and worth taking a drug that you've responded to and presumably can tolerate. After that, we're in the land of clinical experience and patient preference, what people want to do. So a lot of people, especially after their first episode, will want to slowly phase out the antidepressants at that point, or they'll just do it themselves without telling their doctor or whatever. And that's usually fine after a year or two. There are some people who, if they've had lots of episodes of depression, or they've got a tendency to chronic depression, that they should probably stay on antidepressants for years and years and years. And there are some people, including some of my patients, who, being depressed is so awful that they would rather take the antidepressant for the rest of their lives. But that's unusual. The vast majority of people will be able to take an antidepressant ideally for a year or more if they've responded, and then stop it, and they'll probably be fine. With psychotherapy, it's, the standard. It usually takes a little bit longer to get it, and it certainly takes longer for the therapeutic effects to kick in. The average or typical psychotherapy course would be 10, 12, 14, 16 sessions at weekly or sometimes fortnightly intervals. So the treatment's going to take a few months in itself. And then some psychotherapists would offer booster sessions monthly, 3 monthly, or 6 monthly after that. Thereafter, there is sometimes a need, particularly for people in my experience with severe depression or severe mental illness of one sort or another, for them to go back and get booster treatments. But in general, a psychotherapy course is a discrete course lasting several months, and then that's it. And sometimes people benefit from booster sessions, but that's, I think, not typical.
Okay, thank you. And can you give us an idea? It sounds quite optimistic from what I'm hearing, that these things work. Can you give us an idea of what the success rates are like, both with medical therapy and with talking therapy? And is there anything that might influence success rates, make it more likely that they will work?
Yeah. So, the reason I'm optimistic is because the evidence and my experience is that just about everyone with anxiety or depression gets better. It can take a while, but they will almost always get better. So the typical response rates to antidepressants or psychotherapy is around about 80%. So that is including the therapeutic effects of the treatment, but also things like time. These conditions have a natural history of getting better with time, particularly, for example, if they've been precipitated by a stressful cause, then that might have disappeared or dissipated, or people might have dealt with it. And then there's the other kind of non-specific therapeutic factor which helps everyone is a problem shared is a problem half. Discussing it with people helps, and having the installation of hope that things will get better naturally, treatments are going to speed that process up, also is part and parcel. So that's why the treatment effects are in general large. You can get misled sometimes if people want to bring these treatments down, sometimes they do. They sometimes miss out the non-specific therapeutic effects and the placebo effects and the natural tendency, and say, oh, randomized controlled trials show that only 50% of people get better. But that's 50% of people once one controls for the placebo effects, the time effects, and the non-specific therapeutic effects. So both psychotherapy and antidepressants work the vast majority of the time.
Okay, so that sounds really optimistic, that both medical therapy, pharmacological therapy, and talking therapy are very effective in helping people with these conditions. And so what about the small proportion of people in whom they don't work satisfactorily? Where else is there to go? Is there any other therapy that they can move on to?
Yeah, I think, as I alluded to earlier, there's quite a long list, actually, of various augmentation strategies, they're called, to augment the effects of the first antidepressant. So first port of call is usually to change to an older, more effective antidepressant, or to add in some other augmentation agent. So the standard one to use is Lithium, which is a drug that is used to treat people with bipolar disorder, and it's very effective in that condition. Lithium is also known from clinical trials to have appreciable benefits over and above, on top of, antidepressants. So that's the first thing to do. You can then augment that augmentation strategy by adding in thyroid hormone, interestingly enough. Tryptophan is another technique, which is an essential amino acid that sometimes helps. You can go to a different type of antidepressant, again, possibly with lithium or tryptophan. And if those, trying various different antidepressants, various different augmentation strategies don't work, again, we're talking a tiny, small minority of cases here, then I guess the thing that crops up is ECT, electroconvulsive therapy, which is indicated for people with treatment-resistant depression, people who've not responded to 2 or more treatments. It's also the treatment of choice for severe postnatal depression, puerperal psychosis, as it's sometimes called, which is where typically it's comparatively rare, but it's still not that rare, affects something like 1 in 10,000 new mothers, where they commonly think they have these severe suicidal ideas, and that sometimes applies to their newborn infant child as well. So that is an emergency situation where mother isn't bonding with child, may actually have harmful ideas towards the child from a depressive point of view, thinking the child would be better off dead than live in this terrible world, sort of thing. So in those kind of situations, puerperal psychosis or treatment-resistant depression, ECT is the treatment of choice, really, because it can be remarkably effective. And again, it will get most people in those severe states of depression or psychosis better. And it will do so quite quickly as well. It works, it will usually have an appreciable benefit within 2 or 3 weeks. Sometimes you might need 3 or 4 or 5, but it works quite quickly. It's obviously, a treatment that is scary in people's minds because everyone's seen One Flew Over the Cuckoo's Nest, unfortunately, which, despite being a brilliant film, bears no relation to reality in terms of how ECT is prescribed or used. But also ECT involves anesthetics and also, the administration of electricity to the brain to cause a fit, which lasts about 20 to 30 seconds. So there are fairly severe side effects from that. Having a fit and an anesthetic does make you confused and does impair your memory for a good 24 hours afterwards. And then there are sometimes longer term impact on memory. But for those kind of severe treatment-resistant depression or severe psychoses, it's the most effective treatment, certainly in terms of getting people better quickly.
Yeah. Great, thank you. Okay, well, thank you for those clear and detailed answers to my questions. As you know, I asked listeners beforehand to submit questions for me to ask the expert on my podcasts. Are you happy for me to ask you some questions that have been submitted by my listeners?
Yes.
Perfect. So I must stress at this point that it's very difficult to give specific and personalized advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I've summarized the questions in a way which I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualized care and medical management should be sought from one's own doctor. So the first question is, has Professor Lawrie ever suffered from anxiety and/or depression? If so, how has this informed his practice? How would Professor Lawrie support a friend suffering from anxiety and depression? So we start on a personal note.
So yeah, I've certainly had, as we all have, I think, moments of anxiety and depression, and sometimes long spells under stress and duress, where I probably would have met diagnostic criteria for either an anxiety state or a depressive illness. My kind of saving grace, if you like, is I've never been I think probably only mildly anxious or mildly depressed in the kind of grand scheme of things. Certainly not to the point where it's impaired my performance at work. So, I love my job, unfortunately enough, to be able to say that. And so work has always been a bit of a kind of salvation for me. And I've never been so anxious or depressed that I have not been able to work. And so I've never taken or never, consulted anybody or asked anyone for any treatment. although I have taken antidepressants in the spirit of scientific inquiry and experience, just to see what they're like, although not when I've been arguably anxious or depressed. And surprisingly enough, I didn't enjoy the experience of taking fluoxetine. I stopped it after 3 days because I didn't feel very well on it. But then I wasn't depressed at the time I took it. So I suppose what I have learned, if you like, from my personal experience in terms of applying it to my clinical practice is kind of like I said, if you can struggle on, and especially if things are getting better, you can still work, the stresses are maybe being dealt with, then you don't necessarily need treatment. As I said before, the natural history of these conditions is to improve. But if you are seriously impaired, if you are getting worse, if you're suicidal, then I think you should get treatment. So I suppose it's reinforced my belief. Those kind of beliefs come from both personal experience, if you like, and also dealing with patients.
Okay. And the second part of the question is, how would you support a friend suffering from anxiety and depression?
So this happens quite a lot, actually. So being a psychiatrist, possibly, I don't know.
Yeah.
I get asked quite a lot by friends of friends, and sometimes friends, and people who know friends, how to deal with certain situations. So, I think it would probably be more or less what I've been saying up until now. So I would not offer to personally treat a friend or even a friend of a friend, I don't think. But I would certainly give them advice about, when to seek treatment, what sort of treatment they might want to seek, who might be a good psychologist or psychiatrist to go and see, because some are better than others. Let's be frank and open about that. And sometimes, regrettably, I find with the National Health Service these days, you need someone on the inside, so to speak, to guide you through the system. There are various hurdles that are put up at various referral points that people sometimes need to find a workaround. So I think that's my kind of role when trying to help friends or friends of friends. I feel obliged to say, having said that, some psychiatrists and some psychologists are better than others. There's also, and this is particularly true when it comes to psychotherapy, it's also finding the right person for you. And it's just a matter of luck sometimes. Some people get on and other people don't. And that's just a fact of life. And so if you're not gelling with your psychotherapist, psychiatrist, or psychologist, it's always worth thinking about trying to get another one. A so-called second opinion, it's called in NHS terminology.
Yeah, indeed. And to an extent that applies to in gynecology, I think in every field of medicine, actually. In gynecology as well, anything, because we deal with intimate areas and intimate discussions, it really helps if you get along with your doctor and you have a good doctor-patient relationship. Absolutely. Okay, so our next question is that my 14-year-old had significant anxiety during COVID, which resulted in her pulling out her hair. We found that the support was inadequate and we were only offered antidepressants. What can be improved in terms of access for teenagers with anxiety? And secondly, are there any parent workshops which can be accessed for parents?
So, to answer that question, the short answer is, I don't know of any parent workshops in my location, but there may well be stuff in different locations. And it's also true, I think, that child and adolescent mental health services are quite variable across the country. And it's also true that there is a large number of young people, especially young girls, who are suffering from anxiety and depression. It's an increasingly recognized problem. And unfortunately, child and adolescent mental health services just don't have the staff to be able to meet all that demand. So I think the things to do are to try to find suitable information resources on the web, suitable support groups, in and around your area, which may or may not be related directly to the NHS. So some schools, some colleges, some communities have these kind of work and help. They're working towards helping people through various support groups. But it is a tricky problem. The adolescent mental health issue is a big one at the moment. And I don't think the services have really got to grip with it yet.
So yeah, I think this is a really topical question because I'm an adolescent as well as pediatric and adult gynecologist, and I have certainly found over recent years that the proportion of teenage girls, because I only see girls, with anxiety and depression seems to have increased, and more on, for example, on antidepressants. So really support for these girls is paramount, really important. So that may be something that needs to be looked at by the powers that be.
Yeah.
Okay, the next question is, how is anxiety or depression triggered? If you recover, are you always going to be more susceptible?
So it's very commonly triggered by what we call life events, what everyone else calls, stress. Problems at work, problems in relationships, financial difficulties are the big ones. Increasing your intake of alcohol and drugs is quite common. It has to be said, sometimes anxiety or depression just comes out of the blue for no good reason. And, whether or not there is, in quotes, a good reason for anxiety or depression doesn't mean it's any more or less understandable or any more or less deserving of treatment. So it's commonly got a stress and quite commonly doesn't. And just because it may have a stress doesn't mean that people don't need treatment. I mean, the stress may pass, people may deal with the stress, but if they're severely enough anxious or depressed, they still deserve and merit and are likely to benefit from treatment. Yes, both anxiety and depression do have a tendency to recur. Not least, I guess, partly because they tend to come on in young people. A lot of anxiety states come on during people's teens. A lot of depression comes on in people's teens and 20s. So, even from the point of view or the simple fact that they've got 40, 50 or 60 years to live, it's quite likely that they're going to have another episode. But the illnesses over and above that do have a natural tendency to recur. Just like they've got a natural tendency to get better, they've got a natural tendency to recur. So periods of stress, good healthy living are the sorts of things that, again, come up as issues to be aware of and to consider when trying to reduce the risk of recurrence. Staying on an effective treatment for a year or more, as we've already discussed. I think the other thing to mention here, though, is the increased risk of relapse is, we know from depression studies, reduces quite quickly. So after a couple of years, if you have been well for a couple of years after a successful treatment for depression, your risk of another episode becomes pretty much like the general population risk, which is still like, it's quite high. Just like these conditions have 5% affecting the population each at any point in time, they'll affect probably 20 to 25% of the population each during the average lifetime. So the risk is still quite high, even if you've gone beyond that period at risk, if you like. But you can get back down to the kind of population risk level by being well for a year or two, which is another encouraging way of thinking about things.
Yeah.
These things are not usually, they can be, but they're not usually life sentences in the sense of chronic incurable illness or anything like that.
Yeah, that's great to hear. Okay, the next question is, what different types, and you mentioned this before, what different types of anxiety disorders are there? You've went through them in detail, so I don't think we need to revisit it unless you wanted to add something else, but I think you quite clearly explained them at the beginning of the interview.
Well, yeah, repetition might increase people's memories, but yeah, very quickly, phobias in kids tend to respond to simply exposing people to the phobia. Social anxiety tends to come on in adolescence and can be treated with CBT or antidepressants. And similarly, panic attacks and then generalized anxiety tend to come on in adulthood. And they also tend to respond to CBT or antidepressants. But the particular way that you configure the CBT or the particular type of antidepressant can make a difference in the different conditions.
Okay, thank you. Next, what's the link between menopause and anxiety? Why is this a symptom?
So they're very commonly, anxiety and depression are very common symptoms in women going through the menopause.
Yep.
But there has been, and lots of my friends, female friends, tell me that. And so there's no doubt that there's an association. There even used to be a condition a way back when called involutional melancholia, which is a bit of a mouthful, but it just refers to, people coming to the end of their reproductive life and becoming depressed. But actually, if you look at if one looks at populations in detailed studies, there isn't actually a big peak of anxiety or depressive illnesses around about that time, around about the age of 50, give or take. So I think what that means is that anxiety and depression are common symptoms, but they're not necessarily common illnesses, if I can make that distinction at that time. So they're very common symptoms, but I don't think there's a dramatic increase in the risk, in the rate of anxiety states or depressive illnesses at that time. Although antidepressants can still help. I mean, there's certainly fluoxetine, there's some clinical trial evidence for that being a relatively effective treatment in both premenstrual tension and around about the time of the menopause.
Yes, absolutely. Yeah. Okay, our next question is, I'm on lithium and read somewhere that lithium can decrease the risk of getting dementia. Is this true?
Sorry to disappoint you, but I don't think it is. So I think there are some studies that show that, but there are some studies that show it the other way. And so I don't think the evidence for lithium being an effective preventative agent for dementia it's not there. I mean, I don't think we know for sure is the answer. The one thing I would say that probably is encouraging in that regard is there's quite a lot of evidence that having lots of episodes of depression is a risk factor for dementia. So if your depression is treated by antidepressants or very effective mood stabilizers like lithium, that's probably good, and maybe contributing to a reduced risk. But I don't think that we know one way or the other for sure.
Okay, the next question. I've always had a tremor in my hands. It is, I think, a result of anxiety. I was given beta blockers some years ago, but they never helped. I still struggle with this at times, and it can be very awkward and embarrassing. What other medications would help? And adds, I have found cannabis helpful.
So, yeah, tremor is a very common symptom of anxiety. We all have a tremor. It's called an essential tremor, and it is exaggerated in anxiety. There are some treatments. I mean, this is where a neurologist is probably of more use than a psychiatrist. And if you have a severe tremor, a neurologist would be interested in seeing you and making sure it's not, a symptom of some particular condition. It probably isn't. It's probably, in your case, as you say, an anxiety-related exaggeration of a normal essential tremor. And I don't think beyond beta blockers like propranolol that there are no other treatments that occur to me that are likely to be helpful. One could think about diazepam or some of the other benzodiazepines as possibly helpful. I'm not surprised to hear that some form of cannabis has been helpful. That is increasingly recognized, that the various illegal preparations and the various legal preparations of cannabinoids are anxiety drugs, anti-anxiety drugs. Is increasingly recognized that they're quite effective. I have even heard of professional golfers are now routinely inhaling, some are routinely using cannabinoid vapes on the golf course to ease their anxiety, which is manifest obviously in physical ways like tremor and unsteadiness. So yeah, I don't think I've got any kind of I've got no great suggestions there for you, I'm afraid. Feel free to keep taking the cannabinoid in whatever form you might be, and if it's more of a concern, maybe think about getting a referral to see a neurologist.
Absolutely. So that is an answer, isn't it? Okay, so next question is, during my panic attacks, I get severe palpitations. Am I at risk of heart disease in the future from my heart working overtime?
No, is the short answer to that. So
Okay.
I can understand the concern. Panic attacks are routinely misinterpreted as heart attacks. There's people go to casualty all the time with a panic attack, thinking they're having a heart attack, and fortunately they're not. It's a very common experience, but I don't think there is any known risk to your physical health of actually having a panic attack. So I think you can be reassured on that front.
Okay. So the next listener asks, which works better, medication or therapy?
So I think I've kind of alluded to this at least a couple of times. I think they're more or less equally effective. Certainly, I would put CBT, cognitive behavior therapy, above generic psychotherapy or counseling, certainly for anxiety or depression. I would say antidepressants are more or less as effective as CBT. It comes down to, again, as we said before, what you can get in your local facilities and what you want. The only kind of proviso I would add to that is that if you are severely depressed or severely anxious, to the point where you're very distressed, can't work, might be feeling suicidal, that is when you probably want a good dose of a good, strong antidepressant. The evidence isn't overwhelming from the clinical trials, but it's clinical experience is that, people with more severe depressive illnesses tend to do better with the older, stronger antidepressants. And very often people are so anxious and so depressed that they can't think themselves or talk themselves out of it. Sometimes people who are severely anxious or severely depressed can't be reached with psychotherapy or can't use it because they can't think clearly enough, or whatever the reason might be. So there are some people at the severe end of the spectrum of depression that are probably best getting antidepressants, but generally they're more or less similarly effective.
Okay, great. And then again, you touched on this before. What exactly is the difference between CBT and counselling?
So we've talked about CBT a bit. We haven't talked that much about counselling. I mean, counselling can be effective, and at the very least, it's a problem shared, hopefully a kind ear, and some kindly response to people's problems. I think the evidence for it as a treatment specifically for anxiety and depression is less good than for other psychotherapies, particularly CBT. And I think the other thing to be slightly careful of here is that you get very good counselors and psychotherapists, but there's no actual dedicated or recommended or required training for becoming a counselor or a psychotherapist. So it's a slight exaggeration, but almost anyone can say that they're a counselor or a psychotherapist without necessarily having had a formal training or experience. And so I suppose what I would say is that if you are thinking about that, a word of mouth recommendation from a friend or a colleague might be better than anything. But I think if you're going to see a counsellor or a psychotherapist, you would want to know what sort of training they've had, what sort of experience they've had, because that's important, I think.
Yeah, that's really valuable advice. Okay, next question. Is ECT helpful, and does it kill brain cells?
Yes, it's helpful, and no, it doesn't kill brain cells. So to expand on that a bit, it's helpful if, as we've already discussed, actually, if you're very severely depressed and haven't responded to previous treatments, it can be a lifeline. And if you're very ill after giving birth to your baby, it can be life-saving as well. It doesn't kill brain cells. Despite what you might read on the internet, it doesn't. It has nasty side effects, as we've talked about, but it gets people better, and the side effects tend to wear off after time. What evidence there is actually is from structural and functional brain imaging, is that it actually seems to normalize brain structure and function. So if it has any effect on brain structure and function, it's to increase probably not the number of cells, but the size of cells and their connectivity and their function. Brain cells probably shrink back a wee bit when people are severely depressed, and probably expand a wee bit and reconnect a bit better as people are getting better.
Okay, that's an amazing answer. And yeah, that's the genesis of this podcast, actually, to get accurate information from experts, world-leading experts like yourself, rather than just go on the internet and, as we know, the information can be inconsistent, shall we say.
It's a terrible problem.
Thank you.
I mean, if you type schizophrenia if you Google schizophrenia, most of what you will read will not be true. It's the sad truth. Yeah.
Right. Gosh.
I don't know what the figures are.
There's
a lot of rubbish out there, unfortunately.
Yeah, that's the case for most things, isn't it? Okay, so the next question is, what is the evidence for the use of magic mushrooms and ketamine for the treatment of anxiety and depression? Will it impact the bladder? And I guess that refers to the ketamine. But yes, that's the question. So magic mushrooms and ketamine, what is the evidence?
The evidence is slim. So this is a very kind of topical and trendy area, and I am a strong advocate of developing new treatments. That we will always want newer and better and safer treatments in medicine and psychiatry. That's always what we're looking for. And I think magic mushrooms, the active ingredient of which is psilocybin, and various other hallucinogenics and psychotomimetics, as they're sometimes called, like ketamine, look like they've got real potential. And they should be, definitely, we have to evaluate that potential, but that potential needs to be evaluated in clinical trials. And at the moment, there's only, a couple of really quite good ones, and those are quite optimistic in terms of the potential. It looks like they may well be good alternatives to antidepressants for severe anxiety and depression, and a range of other conditions, including PTSD, which we haven't really talked about. And they may also augment psychotherapy for those conditions. In fact, ecstasy was first designed as a drug specifically to augment psychotherapy between the wars. And I think I remember speaking to some old psychiatrists in New York in a previous millennium, and his biggest regret in his career was that the kind of psychoactive drugs had not been thoroughly, evaluated and used as therapeutic agents. And it looks like the time is coming, but we need to know, which drug for which condition, and that takes time, unfortunately. Will ketamine go for your bladder? Well, it seems to, if you take enough of it on the street or in dance clubs, whatever. I'm not sure that we will be using ketamine in that way. So the current way it's used is as a typically in the UK at least as a nasal preparation for a relatively short treatment of severely treatment-resistant depression, for example, and I doubt that is going to cause bladder problems. But I think the risk with street ketamine is taking it regularly for a long time, and I don't think we know whether prescribed ketamine will have that effect or not.
Okay, so still to be evaluated.
Lots of work to do there, yeah.
Lots of work to do, absolutely. Okay. So our next question is, what is the association or interaction between chronic disease and mental health?
A big interaction. There's lots of evidence, lots of studies. So if you've got any chronic illness, diabetes, stroke, roughly speaking, about a third of those people will meet criteria for a depressive illness. So that's a big increase in the risk, from a 5% prevalence at any point in time, or roughly speaking 20% lifetime risk, to go up to 30 to 40% in chronic disease is quite a lot. So there's a strong association. Not surprisingly, if you've got pain or some other problem, it doesn't help. Your life may not help your work, probably won't help your finances, etc., etc. So, and again, just because it may have an understandable explanation doesn't mean it won't benefit from treatment. So antidepressants in the context of chronic illness still work. So again, you may get antidepressants are used all the time in low doses by GPs for pain. And they probably help sleep, as we've already discussed, and they certainly treat depression in the context of stress of whatever cause.
Yeah, okay. And our last listener question is, why is anxiety and depression suddenly so common in young people? Is it society, the influence of social media, or increased awareness and acceptance? That's a toughie.
That's a biggie, yeah. So I think there is some evidence that anxiety and depression are more common than they used to be in young people. But that is not the whole story. It is also much more widely talked about and much more widely recognized. And as a psychiatrist who wants these conditions to be destigmatized, I think that's generally a good thing, that people are more open and talking about it and seeking treatment. The question as to why is a tricky one. We naturally think we blame whatever society-wide issues there might be, and social media, video games, and so on and so forth. They get a lot of blame at the moment, but I don't think there's any good evidence that they are causes at a population level. In fact, there's been some quite nice work done that shows they have, if anything, small effects. I think where those things might come in is for subgroups of particularly vulnerable people. So I think, you can be bullied in a school playground. You can be bullied even more viciously, it would seem, on social media. And there are obviously been tragic cases in recent years where that does seem to have played a part. But I think in general, those things are not the issue. I think so I don't think we know, and this is just kind of speculation on my part. I think the sorts of issues for young people these days about everything seems a bit more pressurized than it used to be, in terms of getting grades at school, to get into university, to get a job, get a house. Those concerns seem much more to the fore in young people's minds than they ever were in mine or in the people I knew of my generation. That we just didn't worry about those things so much. And so I think that may be part of it. The world doesn't generally seem a very good place at the moment for various reasons. And that's a legitimate cause of concern for us all. But so I don't think, it's a bit of everything. It's a bit of the state of the world, a bit of social media, a bit of increased recognition and awareness, I think, is probably what's going on.
Yeah, multifactorial.
As ever, multifactorial, yeah.
That's indeed. So the last question is from me.
Hello.
You have managed many, many patients in your career thus far with anxiety and depression. Given the opportunity, is there anything you'd like to say to patients who feel they may have anxiety and or depression or have been diagnosed with either of these conditions?
Yeah. So I would say if you think you may have anxiety or depression, if you're concerned about it, then go and see someone about it, probably your GP, and speak to them about it. Maybe do the screening tests and so on and so forth. Speak to other people. Speak to somebody above all. And if you do have anxiety or depression, get treatment of whatever sort you can find that you want, because you'll get better. You'll probably get better anyway with time, unless you're very ill, but you'll get better quicker if you get treatment. And if you're very ill, you'll get better much quicker than you would do. So yeah, go and get help, go and get treatment would be my
advice.
Final comments, I guess.
Okay. Okay, so in closing, Stephen, it only remains for me to say a big thank you for agreeing to be interviewed today on the podcast. Thank you for supporting my efforts to educate patients. Thank you for your very, very clear yet optimistic answers. But thank you most of all for all the hard work you've done to help patients with mental health and to help destigmatize mental illness. Thank you so much.
Thank you for asking me, Gail. Hopefully people will find this useful, yeah.
I'm sure they will.
Great.
Thank you for listening. I hope you found it useful. Please keep your eyes and ears open for upcoming episodes. If you enjoyed this, please hit the like and subscribe buttons to raise awareness of this podcast.